All right, hello everyone. Thanks so much for coming today to this session. So I'm Courtney Berrios. I'm the Program Director for Genomic Ethics and Policy here at Children's Mercy in the Genome Center. And I'm really excited for the opportunity to talk to you today about our project where we have been working on really moving from a diagnosis to improved outcomes for children with a rare disease who live in rural communities. So the story of this project really starts with a larger project called Genomic Answers for Kids, which is a pediatric genomic research repository here at Children's Mercy that was developed really to find answers or diagnoses and treatments for pediatric genetic conditions. And if we look at kind of how families kind of move through that study and get into that study, often there's a pediatric patient, somebody recognizes, hey, maybe they could benefit from seeing a subspecialist, and that subspecialist often says, okay, well, we think maybe that kiddo could benefit from some genetic testing. And so that physician subspecialist, often here at Children's Mercy, are the ones who nominate them for this Genomic Answers for Kids project. And they may also be ordering clinical genetic testing in parallel, or they may have already had it. And if a diagnostic result is found through any of those kind of pathways, then that result goes back to that physician subspecialist who can discuss it with the family with genetic counseling support that's provided through the research study or clinically. And a few years ago, we started really looking at who was enrolling in Genomic Answers for Kids and who we might be missing. And so if you look in that kind of, I apologize, it's kind of small in that top right corner. Hopefully you can kind of make out the outlines of Missouri and Kansas in that map. But we partnered with Natalie Kane in the research informatics group here at Children's Mercy, who did some geocoding of kind of zip codes where folks were enrolling. And what we saw from that kind of big picture to talk about today is that if we look at those kind of yellow and green areas around the Kansas City metro area, not surprisingly, that's where we're enrolling the majority of our participants. Those are the kind of like the percentage by population where we're enrolling. But then as we get out into these rural areas, the percentage by population is getting much lower. And because it's percentage by population, we think that means that we are missing some families. And particularly on the Kansas side, there are no other children's hospitals really until you get over to Denver. So we think we're really missing some families that could potentially benefit from genetic testing. And both in our work and in the literature, there's a lot to suggest that where that initial barrier comes is in really getting to that subspecialist who would then order genetic testing and refer on to Genomic Answers for Kids. And so if that kiddo never gets to the subspecialist, then they never get to the rest of that kind of process. And so in 2022, Dr. Anna Cohen, one of my colleagues here in the Genome Center, received funding from Frontiers through a pilot study to pilot this direct to primary care provider model for nominating to Genomic Answers for Kids. So she did some training and partnerships with some pediatric providers in rural Kansas to recognize what symptoms might be suggestive of a genetic condition in a kiddo so that they could directly nominate them to Genomic Answers for Kids. And then just as with any other process, then if there is a diagnostic result that is found, it's returned to that primary care physician so that they can share that with the family and also have that genetic counseling support from the study. And so that study was successful in finding some more diagnoses in these rural children and understanding that we are indeed missing diagnoses that we might expect to have been made earlier in those kiddos. But the trick is that when we make a genetic diagnosis, that very often comes with more referrals to subspecialists. So often we can say, we know this explains certain symptoms that your kiddo is having, but we also know that sometimes these genetic variants are associated with maybe some changes in the heart or some changes in the kidney. And so you often then get referred on to more subspecialists. And unsurprisingly, those same barriers still existed for families. So we had families really struggling with how do I get the care that you're now telling me that I need to get. And so in 2024, I applied for and received a Laura S. Aronson Pilot Award from Frontiers to kind of go to the next step and say, how do we actually try to make sure that these diagnostic genomic findings actually result in improved health outcomes for patients with rare diseases in rural communities? And so very quickly, kind of on methods, we wanted to make sure that we went back at first step to just really hear from the folks who are experiencing this and really know what it's like in the rural community. And so we did in-depth qualitative interviews with 10 parents of rural pediatric patients who had received a rare genetic diagnosis, most of them through that Genomic Answers for Kids program. And then also the primary care providers who work in that rural setting and are caring for these patients. We consulted with the Frontiers Implementation Science Group because we really wanted to really find kind of a framework. We ended up with the theoretical domains framework, one of those kind of determinants frameworks to make sure that we were asking questions that would kind of lead to really understand some of those determinants of care that we could kind of put into action later. And then we used a thematic analysis approach for those qualitative interviews. And I think really importantly, we also had community project team members, Jewel and Kelly, who are both parents of kiddos who, well, actually one's an adult now, but parents of children who have rare genetic conditions and who live in that rural community. And one of them also works in healthcare in that rural community, so really has insight into those, what we were looking at. So what did we find? So first of all, our first set of questions were really about what are the barriers and help us to make sure that we understand those as a first step. And so we heard a lot about challenges to long distance travel. This was every parent, every provider we talked about how travel limited access, not surprisingly. But we did, we kind of came in, I think, in our minds, and we were thinking about really subspecialist care, but we heard a lot about also therapies that they didn't have access to due to travel, really emergency care, particularly that they felt was appropriate for their kid or was knowledgeable about their rare condition. And also we heard a lot about general pediatrics and just how they didn't have kind of general pediatricians that they felt were maybe better suited than kind of a family practitioner to manage rare disease in a kiddo. And so here's a mom at the top quote says, it definitely does impact their care because where we live, it's not necessarily geared for any children that have a special need. We also heard from parents tons of willingness, and they really want to do everything possible to help their kiddos, but sometimes it's just not feasible. So at the bottom here is a mom who says, I don't mind, but it's going to be hard with obviously my work and with my older son and my other son still, but I'd honestly make any effort to do what I need to do for them. We also heard a lot about insurance, and certainly insurance barriers are not specific to rural communities, but in this context, we heard a lot about really not covering local service providers if they did exist, and particularly high costs for out-of-network specialists. And while we heard about telehealth as a facilitator, we also heard a lot of discussion about limitations to telehealth, that it's just not amenable to some services. And families talked about, really getting a child to focus on a screen for an extended time and how difficult that can be, particularly in kiddos that may have neurodevelopmental concerns, which are common in rare diseases. And also about really just the inherent limits to exams and hands-on therapies. So a quote from this mom, she said, things are a little trickier for the boys because they're not right there in person with a therapist. So then I'm having to play therapist for them and trying to help them navigate whatever task or thing for them. And then, of course, we heard about just the physical and human resources and how they're more limited and dispersed if they do exist in that community. So here's one of our providers who talked about, we have a pediatric office, we have pediatric neurology, but when it comes to pediatric diabetes or just pediatric specific cardiology, we just don't have that. So it's always you either go to Kansas City or Wichita. And when they did have a provider, often it was maybe one provider in their area. And so folks talked about having care interrupted when someone might leave and it's difficult to replace them. We also heard a lot about how local clinics just may not be knowledgeable or appropriate for rare disease. And we also heard a lot about these kind of challenges around, particularly about mental health and neurodevelopmental resources that are really needed in those communities. And I put in this quote because I think this is one of the providers, and I think this quote kind of really wraps up kind of how those different barriers can really compound for families and how it can impact them and their relationship with healthcare. So it says, this provider said, for families, of course, they feel kind of hopeless. And then I think, honestly, they kind of lose trust in us, maybe as their primary care physicians, because why couldn't you get me in there? Why couldn't you help me? Why couldn't you get me to this specialist? Even if it might be a transportation issue or whatever, the understanding of how much we can do and not do, I think that's one of the challenges too. So why won't they take my insurance? Well, it's not us, it's them, and it's not even them. But in contrast to that, we also talked with families a lot about what helps you access care, and providers, what helps families access care, and then also what kind of things do you think tertiary care providers and subspecialists could do better, or communities could facilitate better. And so for families, we heard a lot about really just that value of an engaged and supportive provider that can really facilitate referrals, that helps the families really feel heard and supported, and where they feel like they can really ask questions and kind of get in early. And so this mom is saying, I feel like, talking about her primary care provider, like, I feel like she's very open to trying new things, and I can message her, and that she can get new information and they can discuss it. We heard also a lot about the value of connecting to support groups and other families, and how they can kind of provide avenues to get care or information that they're not getting locally. And then we heard a lot about children's development programs, and we had some participants who had maybe lived in one community or one state and then moved to another, and how drastically those resources can vary by state and county, and when that does change, how much of an impact it can have on their access to care, and ultimately on that kiddo's health care and quality of life. And then we also heard a lot about the importance of therapies through schools, and how that can often be the only way that they can access those services, but also that it can be challenging to get there with availability. From the providers had a lot of ideas about how we at tertiary hospitals and others in the community can really support themselves and families better. And so a lot of that focused really around communication and coordination with specialists. And so we heard ideas about, like, could your multidisciplinary clinics maybe provide like a virtual care coordination or like a chart review? So maybe the kiddo doesn't have to come there, but we can send you their chart and you can say, okay, you've got these things lined up, that's great, but we would also recommend these other things and how to access those. We heard a lot about the need for direct communication. Some folks talked about, caring for kiddos who are in a hospital, and they're the only doctor in that region that gets called when a child goes into the hospital, and really the difficulty in trying to decide whether they needed to be transferred or not. And that, maybe if they could just have a one-on-one kind of conversation with a specialist, that maybe they could avoid that transfer. We heard a lot about this need for doctor-to-doctor hotlines, and really wanting kind of a direct portal to communicate about patients with specialists. We also heard about really this desire for subspecialists to really provide resources with reliable information that they can use. And unfortunately, we also heard a few people talking about that they just didn't feel respected by tertiary hospitals and the providers there, that they felt like, they have their unique medical knowledge and knowledge of what's available in their community. And sure, maybe they don't have some of the facilities that we have here, but they felt like they weren't respected for the knowledge and the things that they could provide to families. And we heard a lot about really a desire for more in-person subspecialty outreach clinics, that many of them felt like with the rise of telehealth, they'd been seeing less and less in-person clinics, and that had been really detrimental to their communities. And so particularly in areas around developmental and behavioral health, dietitians, sleep studies, and again, those general pediatricians. Someone's like, could Children's Mercy just send some pediatrician, like some general pediatricians out here on a regular basis? And then we specifically asked about community health workers, because that's something that had been kind of brought up to us as we were designing this study. And some providers weren't familiar with it. Some of them felt like it wasn't really sustainable. But they did talk about, like, maybe if there was a tertiary hospital who kind of supported one of these community health workers who could kind of, work a few of these different communities, like maybe that would be sustainable. And then last thing, we heard about really these desired training and resources. And so they had a lot of ideas about like how we might be able to kind of support them to do more care locally. And so providers said, can I like shadow a subspecialty provider, ideally with CME, for particular skills? So one nurse practitioner said, could somebody just show me how you take a measurement when somebody kind of outgrows their G-tube? I think I could do that here if someone would just sit and show me. They talked about this idea of kind of remote or virtual observation or guidance kind of in the moment. Over on the right is a provider who said, maybe I want to have a certain physical therapy assessment done. We're in Kansas City, you do these like bread and butter. Everybody knows how to do a Hammersmith assessment, but out in Quinter, nobody's even heard of it. So can I have a one-to-one peer education from a physical therapist here to a physical therapist there who says, here's how you do the test, I'll watch you do it. Yes, you did it right, or no, let's do it this way. We heard about a desire for subspecialist training while they can stay in their community. And then we also heard a lot of ideas about kind of seminars for community providers. So talking about educators, therapists, daycare providers, folks who work in WIC, health department employees, people who are really in the trenches with those families from day to day so that they can maybe know better kind of how to help particularly rare disease families that they may not be kind of familiar with their conditions and the needs. So as you can see, we got a lot of ideas from both families and providers about how we could better support their care and access to care. And so this was indeed a pilot project. So this was just a kind of an effort to really get those ideas so that we can then hopefully develop some interventions, and we're working on writing up funding proposals for that now, that we can then try to implement and evaluate on their effectiveness and implementation. And we were kind of reminded of the importance of that as we were doing this, because in contrast to the kind of compounding barriers, we also asked about like what do you see happening when you see a family that does get the access that they need in a rural community. And here's a mom that says, I believe my daughter could have a more fulfilling and better life. And we heard from providers that, I have a happy parent, I have a relatively healthy kid. I feel like I see them less because they're feeling wrapped around in care coordination. So it feels like there can be a real impact by increasing their access and ability to get care. So just acknowledgements to our study team, to the philanthropic funders for the Genomic Answers for Kids, and also to the Laura S. Aronson Pilot Award that funded both this study and Dr. Cohen's study that really directly led into this. So that's all I got. I think we're doing questions now, so I have a few minutes. So, any questions?
Test. Okay, there we go. Great. Okay. I'll start.
Thanks for your presentation. That was very interesting. I wanted to drill down to the point that the parents or maybe providers, I don't know, were asking for more pediatricians. My impression from doing work in rural areas is oftentimes parents don't know the difference between a family medicine physician and a pediatrician. So how did you ask the question, or was that parents that were talking about that?
I'd say that was mainly led by the providers. We did have, I think there was a quote from one who was who just kind of talked about even challenges within kind of their general pediatrician kind of handling that. But I think most of that was really driven by providers that are I have kids that come drive hours to see me because they don't feel like they're getting the care that they need from a family practice provider.
Kind of going back closer to the beginning or whatever, I was really interested in that overlap between things being kind of done twice in a sense, where they're getting the genomic answers for kids, and then they're also getting the clinical genetics testing, which may or may overlap, and then somebody has to explain how the two are different, or why we're getting all this extra testing and why we're doing this twice, and that sort of thing, and how you navigate that, and then how you navigate that. Now we're taking that out into the rural pediatricians.
Yeah, no, so I think it is tricky kind of, and it takes a lot of kind of a discussion with families. And so I think in reality, there are often families that have had clinical genetic testing, and particularly when they're referred here at Children's Mercy, it's that's been negative, and then they get introduced to the Genomic Answers for Kids project. In the kind of rural setting, the families that we talked to, some of them had previous genetic testing, but a fair amount of them had not had any. And so I think in that sense, it was kind of this, they didn't have kind of access to that. And so there wasn't kind of as much overlap for the primary care pediatricians to kind of explain why they were kind of going that direction instead of the clinical setting. But I think it is an important kind of, I think, distinction for families. And we have some families who enroll kind of in that kind of parallel piece of like, I just want to contribute to research, particularly if they've been, you know, struggling for a diagnosis, that will maybe kind of order it in parallel. And so it does happen in parallel, but I think often it really happens kind of more sequentially.
Oh, yeah, wonderful talk. Thank you. For the patients that have the genomic sequencing, what % of them get a result that is not informative? It's an actionable of unknown.
Like kind of like an uncertain thing.
Yeah.
Where, yeah.
And is there the second part of that? Is there like a national database of actionable variables of unknown significance that you could use or compare?
Yeah, so we do find a lot of variants of uncertain significance within that research. In a clinical testing scenario, those are going to be shared back with families. In the Genomic Answers for Kids program, those aren't reported out. It's only ones that we know are pathogenic or likely pathogenic. And so there are national databases. There's like a gene matcher database that I know our analysts work really closely with, that you can say, okay, I have a kiddo with this variant in this gene. We don't know, it's one of those variants that we don't know if it causes disease. And then you put it in this database, and then others can be like, oh, I have someone with that. And so there's a good chunk of kind of publications that come out of this study, of the Genomic Answers for Kids study, that are really those collaborative publications of finding those. So I don't know the percentage, but I would say like there's a lot of variants of uncertain significance. That's, you know, one of the things that we're still struggling with in genomics is really identifying those.
Okay, thank you so much.